in midlife as well, apart from having problems with infertility. Today, we are having an extremely interesting academic session on midlife endometriosis and a great panelists and speakers who are going to talk and give us a lot of insight about midlife endometriosis. Next slide. I'll share screen. Now we'll start the program with the invocation by the Tamil Thai Vazhuthu. Now, I request Dr. Padma to say the midlife prayer.
Midlife prayer. We pray to God to give us grace to accept the midlife physical changes and gently renew our strength. Guide our heart, our mind and body to navigate the way and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's office or who are in bed asking for a healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women, and inspire us to give this gift of hope to others. Thank you.
Thank you, Dr. Padma ma'am. Padma ma'am is the treasurer of Chennai Menopause Society. And now we'll go on to the lighting of the Kuttuvilakku, which is a very auspicious occasion. We consider this the most auspicious in all functions. Now, with the blessings of the Almighty, we'll start off this academic program. I welcome Dr. Hepzibah Kribamani. Madam is a doyen in the field of obstetrics, gynecology, and all aspects, all subspecialties of obstetrics gynecology. I welcome Madam to give the welcome address.
Yeah. Am I audible?
Yes, yes.
Good evening to one and all. On behalf of Chennai Menopause Society and behalf of Midlife Committee of OXY, I privilege to welcome one and all. Respected President Dr. Pushpa Shetty, respected Sudha Sharma, Vice President-elect, IMS, respected President Jairani Kamaraj, chairpersons, speakers, and delegates. It's my proud privilege to welcome Pushpa Shetty, who is very much interested in welfare of men's health. She's doing a lot of public awareness program and academic program. I welcome you, madam. And it's my privilege to welcome my friend, Dr. Jairani Kamaraj, President Oxy, who is a very versatile person, both academic and extracurricular activities. I welcome you, madam. And I welcome my dear friend, Dr. Sudha Sharma, who is a Vice President-elect Indian Menopause Society, who does a lot of research work, and weekly she conducts a club, that is a journal club. And I welcome you, madam. We have eminent chairpersons, Dr. Jayashree Gajraj, Dr. Premlata, and very well-renowned speakers today we have, and Dr. Geetanjali Asma, and dear delegates, I welcome one and all. Today's topic, it's really a confusing topic. We think it is what to do, because one side they suffer with infertility, another side they attain menopause early, so a lot of complication, and it is a continuous thing, lifelong problem. Even after menopause, the endometriosis is going on. So today's CME is going to be very, very useful for our day-to-day practice. And once again, I welcome one and all. Thank you. Am I audible, Premlata?
Yes, madam. Yes,
Yes,
madam.
madam. Yes.
Audible.
So, can we start the scientific program?
Yes,
Yes, madam.
Yes,
Yes, madam. Just Dr. Anshu had a bit of an issue, so I just spoke to her and sorted it out. Now we'll start off with the academic program. The first session, the chairpersons are Dr. Jayashree Gajraj and Dr. Uma Maheshwari. Dr. Jayashree Gajraj, we all know her for a very long time, and madam is really gynecologist par excellence, because madam is such a versatile and dynamic person, and very close friend of ours. Even though she is quite senior to us, we all consider her a very great friend. So she is a consultant in Apollo Specialties Hospital and Mangai Women's Health Exclusive. And I think in all the gynecologists in Chennai and abroad know madam very well. Welcome to the session, madam. And I also welcome Dr. Premlata. Premlata madam is our past president of Oxy, consultant head of the Department of Obstetrics and Gynecology, Dr. Mehta's Multi-Speciality Hospital. So madam was a past president, and it was a very nice working with her for the past 1 year. And welcome to you, madam, also for the scientific session. Now I request the first speaker is Hepzibah madam, none other than Hepzibah madam herself. Madam is going to enlighten us about endometriosis in midlife. Over to you, ma'am. And sorry, madam, we have madam give the welcome address, and Hepsi madam, we all know her so well, and such a dynamic person. We always look forward to working with her, and she will make sure that everything is done to perfection. She has got a lot of accolades, like past president of Oxy, president of Chennai Menopause Society. Madam has got honorary FRCOG. She has got lots and lots of
we can skip Karpagamba, we can skip.
Yes, madam. And thank you so much for being our teacher, madam.
Yeah, I think they have to make me, I'm not able to start the screen.
Yeah, I'll just inform the...
That's because you're having snacks without giving us Hepsi.
Pardon?
They are having snacks without giving us.
I'm Bangalore, Jayashree. I'm supposed to be examiner.
Please check, ma.
Dr.
Okay.
Hepsiva.
Today you are an examiner, Epsi.
Enama?
Dr. Hepsiva.
Today
Yes,
you are examiner today.
yes, finished. Orals we have finished.
And now we can,
Can you see my
yes,
screen?
ma'am, you can make it full screen. Yes, madam.
Yeah.
Yes.
Able to see? Right.
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Right. When the topic is given to me, few questions came to my mind. What is its incidence, its pathology, clinical presentation, diagnostic modalities, and its treatment, and the risk of malignant transformation? So as per the recent WHO estimates, 196 million women suffer from endometriosis globally. And in India, 50 million women were suffering from endometriosis. So American Society rightly said endometriosis should be viewed as a chronic inflammatory disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. So endometriosis is not a problem slowly for reproductive years. So we have a lot of misconception, misunderstanding around endometriosis, including that hysterectomy, pregnancy, or menopause will end the pain. That is not always the case. So endometriosis should regress in parallel with the regression of gonadal steroidogenesis during the menopausal transition seems like a presumption. The elevation in symptoms during menopausal transition has not been shown in longitudinal studies at the tissue level. So it took more than 250 years until the appearance of the first report of postmenopausal endometriosis in literature. So this is just to recapitulate what is perimenopause period according to WHO and NAMS as a period 2 to 8 years preceding menopause and last up to 1 year after last menstruation. So it's really a challenge for perimenopausal endometriosis for the attending doctor and to the patient because they found 16.7% had perimenopausal endometriosis and 4.2% had postmenopausal endometriosis according to the World Health Organization research. And the age group between 45 and 19 years, it was seen 12 per 10,000. And recently somebody has done a study out of which 16,969 endometriosis patient, 40% admitted to the hospital is over 40 years. This is about the incidence. Coming to the pathophysiology, despite multiple pathophysiological theories, endometriosis is still an inscrutable disease, and more so perimenopausal endometriosis. It is very complex because it is not known whether it is a continuation of previous disease or it develops in de novo. So certain theories were postulated, the probable explanation, it can be a metaplasia, induction of endometriotic implants through continued gonadal steroidogenesis, exogenous administration, peripheral aromatization by adipose tissue, in situ aromatization within a cycle of estrogen stimulating cyclogenous activity. Prostaglandin might stimulate aromatization. So coming to the clinical feature, it varies. It depends upon the location, whether it can be a pelvic pain or a mass. And many different locations, especially in postmenopausal endometriosis, have been described. Cutaneous endometriosis has been reported in postmenopausal women, and a lot of rare things are reported: intestinal, urethral, and hepatic endometriosis. So, how to make a diagnosis? It is based on history, signs, and symptoms, corroborated with physical examination, imaging technique, but it has to be finally proven by histological examination. We are doing some study on endometriosis. They insist that we have to have a histopathological report before embarking on a treatment. So the diagnosis, laparoscope and the histological verification is considered to be the gold standard for diagnosis of disease and to rule out a rare incidence of malignancy also before taking a history. We all know the imaging modality is the diagnostic modality, but it has got a specific characteristic in TAS, that is the echogenicity, the components, low papillary structures, very easy to pick up endometriosis from the hemorrhagic cyst, But in TBS, one point we have to remember, it is for any ultrasound, it is highly dependent on the operator. But to make a diagnosis, rectal endometriosis, it's very difficult. And the TBS is very useful. Magnetic resonance, MRI, it's very useful for assess the ureter, bladder, and bowel, but it's very difficult to pick up peritoneal endometriosis. So certain biomarkers, we all know the race serum can be, it may be consistent with having endometriosis, but it may present despite normal serum level. So the CDG recommends the clinician should assess ureter, bladder, bowel involvement by additional imaging if there is a suspicion based on history or physical examination of deep endometriosis before doing a management. Certain conditions can be associated with endometriosis like ovarian or para-ovarian. We have to rule out fibroid, adenomyosis, bowel cancer, and uterine cancer. So the goal in treatment is to alleviate pain, reduce recurrence, improve the quality of patient. So it can be a surgical, medical, or combined. So important thing consideration in this age group include, it is a diminished fertility and the impending menopause. The diagnosis and treatment for endometriosis associated with infertility must be undertaken in an expedient manner because they go for menopause earlier. And all the societies recommend hysterectomy with the bilateral salpingo-oophorectomy as a definite treatment for adnexal masses or a multiple previous conservative surgical procedure in a women whom conservative medical and surgical management failed. Almost all the guidelines recommend same sort of treatment. So the surgery will be the first choice of treatment, mainly due to the risk of malignancy in this. We have to rule out in perimenopausal age group. But this age group, they may have a lot of comorbid condition. So they have a high risk. Nevertheless, the surgery should be considered, explained after all these things to the patient. So certain rules we have to follow prior to surgery for recurrent endometriosis. We have to rule out irritable bowel syndrome, interstitial cystitis, myofascial and vertebral pathologies. So the surgical technique should be individualized and should take into account certain factors like age of the patient, pregnancy intention, cyst features, ovarian reserve, fallopian tube patency, and recurrent status. So it is really, really challenging. I think I don't want to go into the depth because Mala is there to explain what to do. But ovarian endometrioma, clinicians should perform cystectomy instead of drainage and coagulation, as cystectomy reduces endometriosis associated pain. And it should be followed by second line of prevention after cystectomy for ovarian endometrioma, women not immediately seeking conception. Clinicians are recommended to prescribe combined oral contraceptive for secondary prevention. In women operated for endometriosis, we can prescribe post-operative use of LNG IUS or a combined hormonal contraception at least 18 to 24 months. This is to prevent secondary prevention of endometriotic associated dysmenorrhea. Performing oophorectomy rather than cystectomy in a woman with no further pregnancy intention may be advocated in case of high recurrent risk cases. So CDG recommends that the clinicians counsel women with endometrioma regarding the risk of reduced ovarian function after surgery and the possible loss of the ovary. The decision to proceed with surgery should be considered carefully if the woman has had previous ovarian surgery. So to sum up, the surgery plus long-term suppression is required. And it based on patient's requirement, if there is unilateral endometrioma, surgery followed by LNG IUS gives excellent relief. Hysterectomy with or without PSO if family completed a persistence of severe pain. Luna is not effective for pain, and presacral neurotomy is effective but creates new long-term problems also. So post-operative follow-up is mandatory. We can either choose any one of this. And we recently do the diagnosis doing a good job. So recurrence after hysterectomy, it has been reported in various studies from 10% to 85%. And The persistent endometriosis or recurrent endometriosis following laparoscopic surgery, medical treatment might be preferred, and prerequisites histologically it should be confirmed and malignancy should be ruled out. When there is a recurrence, medical treatment can be advocated. But surgery, the management of recurrent endometriosis with a conservative surgical approach, usually it is ineffective. But in postmenopausal, there are no data on the benefit or otherwise a conservative approach in this low estrogen environment. In a report, 75 cases of recurrent endometriosis, bowel involvement was reported in 33% of the reoperated cases. So the medical management, it should be followed. Either it can be a combined oral pill, norethistrodone, Dynogest, GnRH. Aromatase inhibitors are coming into play. In women with pain for rectovaginal endometriosis, refractory to the other medical or surgical treatment, then we can prescribe aromatase inhibitor in combination with the oral contraceptive pill or progestogen or GnRH, which will reduce the endometriosis associated pain. So there was a first reported a case of aromatase inhibitors. The therapy, anastrozole, 50-year-old lady woman who had presented with recurrent endometriosis as a painful vaginal polypoid mass. The pain disappeared in 2 months. The size of the mass also slightly reduced, and at the end of 6 months of therapy, this was reported in a study. So coming to the deep endometriosis, CDG recommends that the clinician should refer whenever we diagnose or suspect to the available treatment in the multidisciplinary context. Performing a removal of deep endometriosis, of course, it reduces the endometriotic associated pain and improves the quality, but it should have a multidisciplinary approach because it can get involved with the rectum or the colon, so many things. So the CDG recommends that clinicians should consider hysterectomy with the removal of ovaries and all the viable endometriotic lesion in women who have completed the family and failed to respond to more conservative treatment. But we should inform that hysterectomy will not necessarily cure the symptom or the disease. Recurrence can happen. So coming to a word about tamoxifen. And then tamoxifen in postmenopausal people may have a breast cancer and this thing, but it increases the risk of endometriosis. So coming to the HRT, it is always beneficial because they have a surgical menopause, which is very, very severe. So we should not deny the hormone replacement. There are a lot of benefits. Only thing we should combine it with the progesterone. So the recommends the clinician to continue treat women with the history of endometriosis after surgical menopause with combined estrogen and progesterone. Tibolone also is another better choice till the age of natural menopause. So coming to the recurrence, the risk of malignant transformation is at least 2.5%. Prevalence of endometriosis varies with different type of ovarian cancer, varying from 4.5 to 90. Ovarian endometriosis is especially associated with clear cell endometrioid types and low-grade seromucinous tumors. And endometriosis is usually not associated with high-grade serous tumors or mucinous tumors. So what are the explanation? It can be a proportion of cases endometriosis may be pre-malignant lesion. The environmental, endocrinological, epigenetic may play a role. Endometriosis may be a metaplastic component of the malignant transformation. These are all the probable hypothetical explanations they are giving. So when they looked at the relationship between endometrial carcinoma of the ovary and endometriosis, the endometrial ovarian carcinoma were found in ovarian endometriosis in 11 cases, that is 26%. In 4 patients, the carcinoma and the endometriosis transition was observed. So they suggested ovarian endometriosis has a potential of malignant transformation in postmenopausal women. Thus, if found, should be surgically removed. So the clinician should inform the endometriosis requiring information on the risk of developing cancer. And some cancer like ovarian cancer and Hodgkin's lymphoma are slightly more common in women with endometriosis. So in perimenopause and early menopause, they appear to be more likely experience early menopause. This is one problem with the endometriotic patients. Either they have infertility or they attain early menopause. So they will have a definitely psychological impact due to endometriosis that also should be addressed. So the management of endometriosis in women approaching the end of reproductive life requires a special attention to the potential for recurrence and transformation into various malignancy. So it's not only a disease of reproductive age, it can happen in perimenopause. When we suspect symptom appear in already known case or a new symptom can appear in perimenopause women, surgery is indicated when medical management fails, but we should discuss about the outcome. Conservative surgery is possible in early perimenopause in this era when women need conception through ART. Risk of malignancy is slightly higher in perimenopause women. So the endometriosis starts at teen, progresses at 30, problematic at 40, supposed to end at 50, malignancy risk at 60, needs follow-up forever. So we have to keep an eye on perimenopausal and postmenopausal women when there is a history of previous fibroid, adenomyosis or endometrioma, so that we can pick up peri and postmenopause endometriosis earlier. So to conclude, challenges is interesting and overcoming them is what makes life meaningful. So perimenopause endometriosis presents challenges in diagnosis, determine objectives of therapy, avoidance or delay in recurrence. By appropriate treatment, we can give them a meaningful life. And thank you for patient listening.
Thank you, Madam. Thank you, Forum, for the elaborate discussion. Madam, I would like to have the few words of Dr. Sudha Sharma and Dr. Pushpa Sethi, Madam, our guest of honor and chief guest, Madam. Dr. Jairani, Madam, had an emergency. She had to leave. So I request Sudha, Madam, to...
Karpana, I'm here.
Remain
Here, Madam. Okay, fine. Okay, Madam.
That is why I called you. I called you to remind you that only.
Okay.
Karpagambal, we have totally forgotten to...
Yes, Madam.
Karpagamal is always in the running sprint, Madam. She is a sprint queen. So she runs and cycles fast, Madam.
Start off with the academic section. So sorry about that. Pushpa, Madam. Dr. Pushpa, Madam, is a practicing obstetrician and gynecologist at Gurgaon, and she was the organizing chairperson for IMS Con 2018. Madam has lot of credits.
I think only one liner. President Indian Menopause Society, one liner. That's all.
Yes, Madam.
Yeah.
Over to you, ma'am. Say a few words about this CME and IMS.
Yeah.
Sorry
So,
about the
thank you very much. And it's always a pleasure coming to Chennai Menopause Society, whether on the physical platform or on the digital platform, because Chennai has done excellent work in whichever field. And I'm really not exaggerating. The members and, Hepsi has been so good. I have no words to describe your society. And you very rightly got the Best Society award this time. And the topic chosen today is really good. I mean, if we say an enigma, endometriosis is an enigma, I think it is an understatement. And Hepsi, I really liked your slide, the last one, that arrow one which says it starts at 20, progresses at 30, and the lines after that. And you are, under a checkup forever. Because actually, at every stage of life, it gives you different spectrum of problem. In the youngsters, the pain, then the infertility time, it's an enigma for the infertility people, really has so many questions which still remain unanswered. And then at perimenopause, it has its own complications, and it really never leaves you. And just like a PCO patient, an endometriosis patient is always under some problem or the other. And I remember some very important questions when I was doing my CIP. The most important question was, when do you give progesterone in a hysterectomized patient together with estrogen? And that was endometriosis. So very nicely covered. I'm so happy that you had your talk before the the welcome, because very nice points and very concise talk. Very nicely you covered all the other topics are very, very relevant today. Fertility sparing surgeries in endometriosis, recurrent endometriosis, alternative therapies, then medical management of endometriosis, a very nice subject chosen. The more you listen to endometriosis, the more you have to learn. Thank you so much for calling me here, and wish you all the best for this webinar.
It's a blessing in this case. Before Chief
Hambal, guest of honor speech. Hambal.
Pepsi, ma'am.
Yes. See, call guest of honor for the speech, pa.
Where is Karpakambal? Okay.
I don't know. She's not.
Okay, right.
Yes, yes, I'm
It's
here,
my
madam.
pleasure to call Dr. Jairani, President Oxy, to give a few words about. Over to Jairani. Am I audible?
Yeah, ma'am. Yeah, ma'am.
Yes, ma'am.
Yeah. Good evening, everyone, and good evening, my teachers, my mentors, my seniors, and my fellow Foxians and Oxians. It has been a great pleasure and honor to be here. A very warm salutes to the IMS President, Dr. Pushpa Sheth, with her dynamic leadership, and the Vice President, Dr. Sudha Sharma, for her energetic talk, and all the more our CMS President, Dr. Hepsi Madam's very dynamic leadership. And we, Oxy, are very proud to collaborate with her for this wonderful webinar. And special thanks to Karpa Hambal, who is the chairperson of this Midlife Committee of Oxy, for joining hands with Chennai Menopause Society to have this wonderful webinar on endometriosis, which we all know it's always a nightmare to treat her from the adolescence to the menopause and even after that. As rightly pointed out, it's a progressive disease with all the aspects of the life being affected right from the day-to-day life, and it has a lot of effects, not only as a pain, it is also affecting the quality of life, the self-image of women, and all the more it has a lot of depressive psychosocial as well as psychosexual problem also comes along with that. And it's really a very important topic to be discussed among the middle life, because this is a life that at that time, this has a maximum peak of its happening of all these events, fertility, quality of life, her career, everything comes into play, and it affects the women in a very, very bad way. And as practitioners, it is our responsibility to know about it more and more. The more we know about this, we have a better quality of treatment for the patients who are affected with that. And I really thank Chennai Menopause Society and my midlife committee for making this topic a wonderful one for the webinar, for all the people to know about it, how we look into them, treat the women in a proper evidence-based treatment part. So in this way, I thank Hepsi Madam and all the Chennai Menopause Society EC Executive Committee and my midlife committee for giving us this opportunity to have this wonderful webinar. And I thank one and all. Over to you, Karpa Hambal.
Thank you so much, madam. Thank you so much. It's always very nice working with you, very dynamic, and you make us think a lot. And thanks for giving us this opportunity to work with CMS and do this webinar. We have a long way to go, and we'll all do our best to make this midlife committee a successful one. Now I welcome Dr. Sudha Sharma. Sudha Sharma, madam, is the former professor and Department of Obstetrics of Gynecology, GMC, Jammu and Kashmir. She has been the vice president of IMS in 2000. She is the vice president from 2024-25 session. She is secretary general of IMS 21 to 22 session. Honorary professor of IMA and
Thank you, Dr. Saidam. That's fine. Thank you so much.
Over to you, ma'am.
Thank you for such, nice introduction, kind words. A very good evening, dear friends. Chennai Menopause Society, OGSS Midlife Committee, our chief guest, and all friends from Chennai. first of all, our heartiest congratulations on being awarded as one of the best society at national level. I think 3 cheers. Dr. Hatsiva, you and your entire team for doing such an amazing and unstoppable work. I must say that. And I think this is Dr. Pushpa's first virtual webinar, if I am not wrong, as president, and we wish her all the best. And Dr. Hepsiba, you've chosen such an important topic, endometriosis, which we expect a disease of the reproductive age, and we expect it to wean off, once we reach this menopause. But you have so beautifully highlighted the importance of this disease in midlife, the malignancy part and the premature, menopause in this disease. And you very clear-cut messages you've given, and you have invited such a star faculty as chairpersons, as speakers, panelists. So we are here to learn more and more about it. Everyone has said the same thing. The more we hear about it, the less it is. And every time we listen to it, we carry home some new message. And it definitely the benefit goes on to our patients. So all the very best, and thank you for making me a part of it. Thank you, Dr. Hepsi.
Thank you so much, madam. We are very happy to have you here. Sorry about the small confusion.
No.
Not having the welcome
Some
speech
things should be out of box also.
No, sorry, madam.
It's a big confusion. It's a big confusion.
That becomes more interesting and, in a different way.
And we all listen to Hepsi ma'am's very nice talk. I always get impressed with Hepsi ma'am's talk because madam's approach of presentation is very good. And she has a nice saying at the end of every lecture and session.
It's not only presentation. It's the way she presents herself with such a beautiful flower. We always remember her like that, and her friendly approach. We are somewhere, we would, click ourselves together and academics at par. Excellent.
Definitely, madam. Thank you so much, madam. I can see the passion in all of you, doing so much of good work in IMS, madam. Thank you so much for being with us, madam.
Karpagamba, you didn't introduce the chairpersons also.
Chairpersons, yes, madam. Now, I introduced madam. I'll introduce once again, madam. Dr. Jayashree Gajraj, madam. No, this is the previous session, the previous session. The first session one. Jayashree madam is a very close friend of ours, and she is a friend of everyone. Madam is a senior consultant OBGYN at Apollo Specialty Hospital and Mangai Women's Health Exclusive and MGM Healthcare. And madam has been the past president of Oxy and past chair of AICC RCOG South Zone and founder secretary of and immediate past president of Chennai Menopause Society and president of 18 RCOG, president of SOFC. And she received the Best Doctor Award from Dr. MGR Medical University. And she has a lot of publications and chapters and textbooks to her credit. Now, Dr. Premlata madam. Premlata madam was the past president of Oxy for the previous year. It's been extremely, I've been very fortunate to work with her in the last year. She is the consultant head of the department ONG, Dr. Mehta's Multi-Specialty Hospital, Chetpat, Chennai. And she was former professor in obstetric and gynecology at Institute of Obstetric and Gynecology and Madras Medical College. She has vast experience, more than 35 years in teaching undergraduate and postgraduate students in various medical colleges. And she is also a DNB examiner. And she has presented papers in national and international conferences. Madam is an expert in tubal microsurgery, infertility and laparoscopy. Thank you, madam. Now, I'll go to the next speaker, Dr. Deepa Thangamani. Deepa CV. Actually, there was a bit of a network issue with me, madam. I'm not able to share the slides. So I'm asking Chitrakala to do the same. So now, the next talk is on medical management of endometriosis. Now, we all know that it's going to be delivered by none other than my very close friend, Dr. Deepa Thangamani. She's a consultant at Apollo First Med Hospitals, Chennai, and also at Tamari Fertility Solutions Exclusives, Chennai. So she's a joint secretary of 18 RCOG, joint secretary of Chennai Menopause Society, and advisory committee member of Oxy this year. And her areas of interest: gynec endoscopy, emergency obstetrics and intrapartum care, and ART. She's a clinical examiner of a Part 3 MRCOG since 2019 and member of lot of societies like OXY, 18 RCOG, IMA, CMS, IAG, ISOPAR, SOFC, and OGIN. Past member representative of AICC RCOG South Zone and Indian Representative Council London. Over to you, Deepa. Deepa is going to deliver a lecture on medical management of endometriosis. Over to you, Deepa. Yeah, can you share the slides?
No, I'm just struggling to share my slides.
Exactly same problem with me. So I asked Chitrakala to do the same. So the slides were a bit jumbled.
Post only. Thank you, Chennai Menopause Society as well as Midlife Oxy Midlife Committee for inviting me to deliver a talk. Thanks, Jayrani Madam, and thanks, Sepsi Madam. I'm still struggling to share.
Chitrakala, can you just sort that out, ma?
Ma'am, you can't see any icons in the below, ma'am.
Yes,
I can see share screen, but
Yes,
it says you can't share.
Ma'am, you're already a co-host, ma'am.
Yes. There is some problem. I don't know. My screen, my thing is not coming.
Yes, ma'am. Now it's visible.
Yeah, now it's visible, right? Okay.
Yes, ma'am. Yes, ma'am.
Okay. Thank you. So I start with little bit of basics. We know the types of
Ma'am, the PPT is not visible. Only the screen background color is visible.
Backdrop is seen, Deepa.
Okay.
Have you opened your presentation? Have you, Dr.
No,
Deepa,
I opened it. Is there on the screen.
Have you made it enable?
Can you please unshare and share once again, ma'am?
Okay.
Deepa, did you select on the presentation?
Yes. 1 second. You can able to see my desktop?
No. We were able to see your background screen, Deepa, that purple thing.
Okay.
But the slides were not visible.
Now you cannot able to see anything, right?
No. No.
Now?
Now, yeah, we can see your screen.
Desktop screen only, ma'am.
But I can't see anything in the desktop also now.
Have you minimized it down?
Yes, I minimized it down. But I can't see the desktops, other things in that.
Ma'am, while sharing this screen, don't click on anything, ma'am. Please click on the share screen.
Okay, I said I done share screen.
Ma'am, stop.
Okay.
Now, please click on the share screen, ma'am.
Yes.
Don't click on any other icons, ma'am. Just screen and share, ma'am.
I just screen and share, but I couldn't able to see anything.
Karpa, you can mail your thing to Chitrakala so that she will be able to, by the time the next.
Okay, madam, I'll mail it. Karpa, can you go with the next speakers? I'll just mail my presentation.
Yes, ma. Yes, Deepa. I will carry on with the next speaker. By the time Deepa sends his presentation to Chitrakala, I'll request Dr. Mala Raj. Dr. Mala Raj is also a very good friend of mine and also in the Oxy Executive Committee. She is the founder secretary of IAGE Tamil Nadu chapter, managing council member of IAGE. She has lots and lots of credit to her. And I think this page is not enough, but she does advanced training in gynec endoscopic surgery, which is approved by Foxy. And she's trained in aesthetic gynecology and accredited menopause practitioner. She received the Best Doctor Award from Tamil Nadu MGR Medical University and Best Video Award in IAG 2018 in Lucknow. And she is an operating faculty in various conferences all over the country and abroad. And she has received so many awards. To mention a few, Dr. Sivli Rudra Sinha Award, Dr. Satyapal Award, and authored many chapters in various textbooks. And she's currently the managing director of Firm Hospitals. Over to you, Dr. Mala. Dr. Mala is going to talk about fertility sparing surgeries in endometriosis, which is a very important aspect because of even in midlife, there are a lot of women we come across who want to retain their fertility.
Thank you so much, Dr. Karpangabal, for the nice introduction. So good evening, everybody. So at the outset, I would like to thank Oxy and the Chennai Menopause Society for this opportunity. Respected President of IMS, Dr. Pushpa Sethi Madam, and the Vice President of IMS, Dr. Sudha Sharma Madam, our Hepzibah Madam, the President of Chennai Menopause Society, and our President of Oxy, Jairani Kamraj Madam. And thank you so much for this excellent initiative taken by Jairani Kamraj Madam for the collaboration with Chennai Menopause Society, and also forming various committees like this to stay focused on some particular activities. So there is one small box visible. Can we? Yeah, fine. Yeah. So the topic given to me now is the fertility enhancing surgery in endometriosis. As we all know, when it comes to endometriosis, there are two problems that we have to anticipate. One is the pain, and the second one is infertility. So when it comes to pain, we already have a speaker who's going to talk about the medical management. So that is beyond the scope of my presentation. So I will stay confined to the fertility aspect of endometriosis. How are we going to manage the fertility of these women with endometriosis? As we all know, endometriosis is a chronic inflammatory disease, and it is really a progressive one. It just keeps advancing only with age, unless and until the hormones wanes off from the body. So, but it doesn't stop with that. It goes even beyond menopause as well, and it has become a major public health problem because it definitely affects the quality of the women, and as a result, her working capacity is also compromised. So, and it becomes an economical burden because of the treatment and the cost associated with this particular disease. But in spite, with the availability of all the high-end diagnostic imaging and other thing, earlier laparoscopy was considered as a gold standard for just diagnosing endometriosis. But then now we have other modalities to diagnose endometriosis. But when it comes to the treatment point of view, of course, laparoscopy is the gold standard. So when dealing with endometriosis, one should understand the endometriosis life of a woman, because it starts way back during the adolescent period itself, as beautifully highlighted by Hepzibah Madam. It starts at 20 and goes even beyond menopause. So endometriosis in infertility, if you take, in fact, 60% of the infertile women are affected with endometriosis. So the main problem, how it causes infertility in these women, are mainly by mechanical obstruction of the uterine tubes. Here, the tubes are not obstructed because of any kind of a mechanical obstruction. This is, not because of any block. It is only because of the mechanical obstruction which occurs because of the distortion in the anatomy. Next, it also alters the ovulation process because of the change in the hormones. Especially, there is an increase in prolactin in these women with endometriosis, which hampers the ovulation. And also, again, the receptivity of the endometrium also is affected, and as a result, it impairs implantation. That is the reason why we are not able to get very good success rate even in case of IVF. So, of course, little bit about the endometriosis, as we all know, mainly because of the reflex menstruation, and there are various theories associated with endometriosis. I'm not going to touch any of these. But one thing we should understand is that why early diagnosis is important is because it starts way back in the neonatal life. Any neonatal baby which has any kind of bleed in the early phase, that is immediately after the birth, we should have a suspicion that this particular child can develop endometriosis, and that should be a warning sign for the mother as well, so that if she has any problem during the puberty, she can bring it it to the notice of her gynecologist so that, necessary actions can be taken and we can diagnose the disease at the early stage so that it does not hamper her fertility in the future. And this is mainly because of the immunological nature of the child. See, not all the reflex menstrual fluid develops into endometriosis. Is only when the immunological function is compromised, the metaplasia of these cells occurs and they develop endometriosis in the future. And of course, now quite a lot of lights have also been thrown on the genetic and the epigenetic changes which occurs with this particular disease. The most important thing what we need to understand is that of the fibrosis. This fibrosis is the main culprit for the pain and also for infertility. So that is the reason why most of the medications have their limitations when it comes to endometriosis, because when there is so much of fibrosis, as in case of deep infiltrating endometriosis, these pharmacological agents do not seem to be having any great role. So unless and until we remove this fibrosis by surgical method, the women will not get pain relief, and also at the same time she will not be able to conceive. So of course the pain in endometriosis is mainly because of the nerve entrapment and the nerve, because the pelvis is fully innervated, and these are the changes which takes place because the peritoneal fluid contain lots of growth factors which promote angiogenesis. And also it has been found that many of even the wheelchair patients have become mobile once the surgery for deep infiltrating endometriosis have been done properly, and also women with deep infiltrating endometriosis can conceive after a proper laparoscopic surgery. So of course we have various type of endometriosis depending upon when she presents, the fertility potential of that woman is affected. So if she comes to us very early in life, in the early stage, as in the case of superficial or the surface endometriosis, once we remove these surface endometriosis, her fertility potential returns back to normal. But when it goes a little beyond that stage, the endometrioma stage, of course, the endometrioma needs to be removed so that the ovarian reserve is not further affected. And of course, in deep infiltrating endometriosis, we have enough evidence to show that surgery is a better choice for these women. So of course, the peritoneal endometriosis, it is mainly the peritoneal factors which hampers the fertility. And these are the few reasons why it affects the fertility. And of course, when it comes to the endometrioma, there is always a constant debate whether to remove the endometrioma or not to remove an endometrioma in women with infertility and endometriosis, because we need to understand that the more we wait and treat her medically, the endometriomas are going to grow. And as we all, you can see, the endometriomas are mainly going to compress on the follicles, and as a result the AMH is going to be reduced, and they also secrete reactive oxidized iron, and as a result the follicle growth is affected. So owing to this complexity, there is always a constant debate about how to optimally manage a women with fertility in endometriosis. So we have quite a lot of literatures. I just want to highlight only one literature where it very beautifully states how endometriosis can be treated in a woman with infertility before IVF by a proper laparoscopic surgery, where all the deep infiltrating endometriosis can be removed. So this is a meta-analysis of about 22 studies where the IVF pregnancy rate sharply decreased with advanced in endometriosis, and they have found that with the laparoscopic surgery, it has been found to improve just before the IVF procedure. So they have categorized into two groups. One group where IVF was done, and another group laparoscopy was done. And these were the criteria for these patients. And they found that the women for whom the laparoscopic surgery were done prior to IVF, they had a better fertility outcome. So this IVF laparoscopic group and the IVF group, they compared the number of oocytes retrieval, the fertilization rate, the embryo quality, the implantation rate, and the pregnancy rate. And they found that in the group where the laparoscopic surgeries were done, the implantation rate was also better, and also the pregnancy rate was also better compared to that of a IVF group alone. And again, in laparoscopic surgery, so they also compared how in case of deep infiltrating endometriosis, where they removed only the fibrotic endometriotic deposits, that is doing up the proper clearance of all the endometriotic lesions without without any endometrioma, they found that these women fared better than that of those who had an endometriomas which were removed. So laparoscopic surgery for deep infiltrating endometriosis has been found to be benefiting for these women with deep infiltrating endometriosis. So the conclusion of this study was that laparoscopy should be an option for women who have failed IVF, and also excision of the infiltrative lesions both in the uterosacral and the colorectal regions also seem to be improving the fertility potential. And although they had only a few oocytes which were retrieved from women in group B, laparoscopy group compared to that of the IVF group, the fertilization rate and the quality of the embryo transfer were almost similar, and this adds to the benefit of the surgery before IVF for women with deep infiltrating endometriosis. And disease removal is associated with improvement in oocyte function, quality, and embryo implantation. So fertility enhancing surgery in endometriosis really enhances the fertility potential of the women, because in the early stages, if it is tackled, they will not compromise on the ovarian reserve and improves her fertility. So the rationale in surgical treatment is complete removal of all the lesions, and we have to obtain a long-term pain relief for these women, because pain again is a main factor for infertility because of dyspareunia. There will be quite a lot of marital disharmony, and also it reduces the recurrence rate, enhances the fertility, and also protects the functionality of the involved organs. So few video demonstration of this particular surgery. So here you can see women, that is after first child, she came with severe abdomen. In fact, first child I had delivered her, and then she came with severe pain, and an ultrasound did show some endometriotic. In fact, ultrasound was suggestive of ovarian cyst. But when I introduced the scope, I found these kind of endometriotic blebs all over the entire pouch. So this is again the major factor for her infertility and also for her pain. So if you see, the ovaries are apparently free. So these are mainly the peritoneal endometriosis. So unless and until we remove all these peritoneal deposits, she will not get any relief from pain, and also she will not be able to conceive because of the peritoneal factor hindering her pregnancy. So we need to make sure that all the peritoneal deposits are removed safely, and these peritoneal deposits also have to be removed completely without leaving any bit inside the abdomen, because these left behind can again grow back into her, further develop into endometriosis. So we need to make sure all these blebs are all removed, and I had to put all of these inside the bag. And there were few which were also going very close to the rectum, that is the one which was very close to the rectum. So we had to remove all of that, and then finally remove all of them in a bag so that she could get some kind of a pain relief, and also she could conceive. So that is the endometriotic cyst, which we can see that it is burrowing inside the rectum. So we have to remove all of that, and then with that, the entire pelvis was cleared, and then the pouch of Douglas was also free. You can see that the integrity of the rectum is also being checked, and she had she was free from pain. So this is the one kind of peritoneal endometriosis. So many a times we see that if we are able to catch them in the early stage of endometriosis, like these peritoneal endometriosis, which are called the peritoneal pockets. These are the early signs of endometriosis, also called as Allen-Masters window. So many times during diagnostic laparoscopy, we may see some kind of pockets like this, because these may not be visible in a routine ultrasound. So the most important thing is we have to understand that these are the early signs of endometriosis, and we have to open up all these peritoneal pockets so that the disease does not progress, and advise her accordingly to conceive as early as possible. So here you can see that apparently the ovaries are pretty normal. So once you clear all these lesions, and the tubes are also going to be normal, because as we all know, in endometriosis, the tubes are not the problem. It is only the mechanical obstruction which creates problem for the tubes. So once we they clear all of this, they will be able to conceive. And as you can see, the tubes are quite patent, and any kind of endometriotic deposits should be ablated. So here you can see that endometriotic deposits in the peritoneal cavity are all being cauterized and being removed. So another next stage would be the ovarian endometrioma. So if we miss them in the early stages, then they can develop into an ovarian endometrioma along with that of the peritoneal deposits. So again, here the technique of surgery is very important. We have to follow the principles of fertility enhancing surgery so that we do not compromise on the ovarian reserve. As it is, the ovarian reserve would be compromised in these women with endometrioma. So the art surgical techniques are quite important. So we have 10 simple steps in case of managing ovarian endometrioma. First, we need to have a proper diagnosis, and second, we need to identify the right plane for which we use the injection of vasopressin or the pitocin. So ideally speaking, we have to avoid any kind of energy source on the ovary. So to avoid the energy source and to secure hemostasis, vasopressin is a very good molecule where in the dilution of 10 units in 100 ml, you can inject it between the cortex and the cyst wall, and once the cysts are decompressed, we can gently peel off the entire cyst wall. So you can see that without using any kind of a cautery, the entire cyst has been peeled off, and the ovaries, because these are normal size ovary, you can just put pressure onto the lateral wall of the pelvis and they will regain the structure. So the most important thing here is that while injecting the vasopressin, always try to inject it between the cortex and the cyst wall so that it will peel off very easily, and the blood supply of the ovary is only from the hilum. So while if you are using any kind of energy source, very cautious not to use anything near the hilum, and just use only spurts of bipolar if it is necessary. So the cyst wall can be peeled off very well like this, and all the endometriotic deposits which are found can also be ablated. So finally, you can see that you won't have used any kind of an energy source on the ovary. As a result, the ovarian reserve is not compromised. And then finally, we have to make sure that put them inside the bag only and then remove it. Do not remove them naked, and port site is closed. So these are the 10 little steps that we generally follow in a case of a cystectomy, in a case of an ovarian endometrioma, which I had described in the surgery. So ultimately, standardization of laparoscopic cystectomy for endometrioma could make the procedure very simple and safe. And this is a case of endometrioma. Again, this particular lady, she had an endometrioma and then she was waiting for surgery. That was a time when there was we had the pandemic, so had pushed her off a little bit, telling that we will do it after the situations improves. And then but then once night she came but with severe pain, and then she had ruptured that ovarian endometrioma. And if you see, her CA 125 was more than 2000. So when the CA 125 is alarmingly high, not necessary it has to be a carcinoma, it can be a rupture of the endometrioma, which we need to keep in mind. So we had to take her up as an emergency and do a cystectomy. Of course, she was newly married, so we didn't have we had to make sure that we do a proper cystectomy and take her care of her ovarian reserve. And of course, within 6 months, she did conceive. And of course, you can see that the cyst wall is being peeled. In such cases, we can also reconstruct the ovary so that the ovarian structure is retained and it does not cause any kind of additions to the surrounding structures and alter the tubo-ovarian relationship. So this is again a case of recurrent endometrioma, wherein the endometrioma surgery was done earlier and then she had come again with a recurrent one. So always a recurrent endometriosis is a challenge because the anatomy is going to be totally distorted. And again, you have to first make sure that we restore the anatomy and only then do a cystectomy. That is the most important dictum which we need to follow. Always restore the anatomy and then peel the cyst wall. Do not try attempting a cystectomy before restoring the anatomy. So you can see that all the bowel and the surrounding structures are adherent. So we have to gently make sure that you dissect all of them. And then, of course, these cysts will definitely get ruptured. So the point of punctum is what we generally extend the incision a little bit to peel the cyst wall. So this has been, you can see that the entire anatomy is now, the ovary is restored. The ovary is now dislodged from that of the pouch, and then a cystectomy is being performed. And once a cystectomy is done, if the ovaries are little, the edges are little ragged, then we can reconstruct them by taking 2 or 3 stitches on them. So this is the again a girl for whom I had done adolescent endometriosis, who came with a big huge endometrioma, and cystectomy was done, and then I had put her on Dynogest. I told her to continue it until she get married. Of course, she did get married within 2 years of the surgery. She was only 21, but the family was very anxious because of the disease. And then she came back after surgery. In spite of being on Dynogest for almost 2 years, she came with pain. Of course, she didn't have any cyst, but this was what I saw in the hysteroscopy. You can see how much of endometriotic has endometriosis had affected the glands. Okay, so here this is the inflammation which has been produced by the endometriosis. That is because it is a progressive disease. So even whatever medical management, see, she doesn't have any cyst. So it is just that the inflammation of the disease was the reason for pain. So all these additions were released, and then now she is under treatment for fertility. So this is another very interesting case where the patient was referred to me for from Bangalore for a bladder endometriosis, but then she came with an MRI of bladder endometriosis. But then when I had when I saw this was with bilateral endometrioma. So on laparoscopy she did have bilateral endometrioma. So the endometrioma surgery was to be done. But before that, I wanted to see how her bladder was. So in case of any preoperative diagnosis as a bladder endometriosis, we should always look at the anterior surface of the uterus. But when I saw the anterior surface of the uterus, it didn't look suspicious because it was quite free. So if it is going to be a bladder endometriosis, invariably we can see some kind of a deposit, though there was few brown spots visualized. So decided to do a cystoscopy first and then look at the growth in the bladder. So when I put a cystoscope, you can see that there was a papillary growth inside the bladder. So this papillary growth did not look like an endometriosis, because invariably when you have an endometriosis, you will have a bluish ecchymotic discoloration of the bladder. But unlike that, she had just a papillomatous growth. So my initial plan was to open up the bladder and do an excision of the bladder endometriosis. But on looking on cystoscopy, this was just a papillomatous growth. So decided to remove this papillomatous growth through just gentle resection only. So like how we do a hysteroscopic resection for the myoma, this bladder papilloma was resected, and it was sent for biopsy. You can see at the end of the surgery, the entire growth was completely removed from the base of the bladder with no damage to any of the bladder musculature. Of course, the other areas of the bladder were apparently free. Even the osteas were also visualized, and this was sent for biopsy, and it did come as inverted papilloma of the bladder, which is a benign condition. So this particular lady used to give some passing of fleshy mass in the urine. So that added to the confusion and suspicion of bladder endometriosis to everyone. But then after this, she was absolutely symptom-free, and she is on fertility treatment. Of course, this endometrioma, as I mentioned earlier, we had to follow the principle of fertility enhancing procedure, and the endometrioma was removed finally, and then reconstructed by suture in the ovaries. Because they were huge endometrioma, I generally believe in reconstructing the ovary so that the raw areas are not exposed. So because once the raw areas are exposed, they will attract adhesions, and it will add yet another factor for her infertility, that is the tubal factor, by altering the tubo-ovarian relationship. So this is a case of bladder endometriosis. This in fact is from the net, because I just wanted for completion's sake to show a clear-cut bladder endometriosis. So in case of deep infiltrating endometriosis, even in the rectal nodule, so we have to make sure that the rectal nodule, but this we need the help of our colorectal surgeon to remove these nodules. So there are enough literatures now saying that in case of rectal nodule and all that, there is no role for medical management. We have to make sure that we excise all of these and then remove, not only just for pain relief, but even for fertility, with the literature which I had showed also highlights that. So this is again a deep infiltrating endometriosis. So again, you have to make sure that you make sure that the anatomy is first restored. So all the adhesions would be present invariably. So we have to clear all of these adhesions, and then we have to make sure that the anatomy is restored, and most of them will conceive automatically. So this is just a small little slide to show how hemostasis can also be secured. If you don't want to use energy source, you can use also a snow to just place it on the bed of the ovary, and then thereby it secures the hemostasis. So again, the Intercit can also be applied, but only most important thing is you have to make sure the hemostasis is well secured. Though Intercit is an adhesion barrier, if hemostasis is not secured, it will attract adhesions. So in endometriosis, you have to be very cautious while using Intercit, because most of the time it will not be completely bloodless. So endometriosis again is when it comes to fertility, the women keep suffering from in silence, not only with pain but also emotional anxiety. So we need to make sure that we take adequate care to help her out. So fertility enhancing surgery has a very major role for endometriosis in infertile women. So thank you so much for the opportunity and patient listening.
Thank you, Dr. Mala. That was an extremely exhaustive and very interesting presentation. And I always think that, endometrial surgery, first time, well done. So now, Deepa, are you ready with your presentation?
Mala, I would like to ask you one question, Mala.
Yeah,
what is the cutoff? They say, guidelines say if the endometrioma is less than 4 centimeters, we need not go for a dissection, especially for IVF, before IVF. And also, whenever we do the dissection, it's better to restrict the energy sources. You can do mechanical dissection, hydro dissection, so that the damage to the ovaries are less. Also, should we do routinely an AMH before and after, especially in a fertility preservation surgery?
So regarding the size of the endometrioma, ma'am, as you rightly mentioned, 4 centimeters, we take it as a cutoff. But only thing is, we have to look into the other factors also. We cannot just blindly go only with the size. We have to look at the age of the patient and also the other factors which are associated with the infertility. Because if she's an elderly woman, then again she has yet another risk factor, that her ovarian reserve are going to be compromised because of her age. And she also has this endometrioma, which is going to double it up. Okay, so if the woman is very young, newly married, and if she has an endometrioma up to 4 centimeters, we can definitely try with medical induction. Controlled ovarian stimulation is good enough. But if she is not responding, and then if the endometrioma is growing, then it is better to go for a surgery and do a proper fertility enhancing surgery like what I was mentioning. So we have to look at the age and other factors when it comes to size. Then again, when, as you mentioned, energy sources should not be used, madam. So for which we are using vasopressin. You can inject vasopressin either into the uterus, or you can also inject it in the infundibulal pelvic ligament, or as I mentioned, you can inject it on the ovary between the cortex and the cyst wall. So it's most of the time when you are injecting you can see that the vasopressin comes out, or sometimes the endometrioma ruptures. There is no harm. We have to just suck out the chocolate material and then clean it up. And again, we can inject the vasopressin, because now the field is very clear. You can go inside the cyst, the ovary, and inject it on the cyst wall. So just a little bit of this will not require much of an vasopressin. Just hardly 4 or 5 ml is all that is needed. So, but that will give us a very good plane. So we do not have to use any cautery at all.
Thank you, doctor. Thank you.
Thank you, ma'am.
Thank you, Dr. Mala. Deepa?
Yeah, Chitra, can
yes,
you
ma'am. I am sharing, ma'am.
Yeah. Thanks.
Okay.
Good afternoon, everyone. Next slide. Sagdi, change the slides. Yeah. There are, so as Mala already discussed, it is my tough job. My Mala has convinced the audience that surgery is the treatment. But I'm just trying to tell that what is the role of medical management before or after surgeries? Is it really indicated, and how long? So before that, I'll just touch the basics. We know the types of endometriosis, which is the ovarian endometrioma, pelvic superficial endometriosis, which is peritoneal endometriosis, deep endometriosis, and deep rectosigmoid endometriosis. And next slide. So the goals in the management of endometriosis, we have to treat the symptom. Suppose if the symptom is pain, alleviate the pain. If the symptom is infertility, assist fertility. And reduce the delay in diagnosis and medical management. So to preserve, don't diagnose the endometriosis a little early. And so in order to preserve the fertility and in order to prevent the progression of endometriosis to the chronic pain, whereas Dr. Mala said the fibrosis is very, very difficult to treat with the medical management, as well as surgery will be the main treatment. So reduce the unnecessary surgeries and prevent further surgeries is the third important goal. That is the importance of post-surgical maintenance. Next slide. So we start with the clinical scenarios. This is a 32 years, para 1 living one. She had a child, LCB is 8 years. And now she presented with a new onset dysmenorrhea, mood swings, PMS, and non-cyclical pains. She is not planning for pregnancy. So with this symptom, shall we diagnose endometriosis? So what SJ 2022 says that endometriosis associated pain includes dysmenorrhea, dyspareunia, dysuria, dyschexia. So we can consider the diagnosis of endometriosis with this clinical background. So next slide. So what will you do? Will you do any investigations? Next slide. Change the slide. Yeah. So will you do the imaging like MRI or ultrasonogram or DLAP? So DLAP is no longer the gold standard. So even if it is a negative imaging results or where empirical treatment are unsuccessful, then the recommendation is offer laparoscopy for the diagnosis and treatment of suspected endometriosis. So in these conditions where the lady doesn't need any fertility treatment and not planning pregnancy, probably without any negative imagings, we can still start an empirical treatment for an endometriosis. That's what the SJ guideline says. Next slide. So these are the important diagnostic factors. So main focus on medical history and clinical examination. Next. So as I said, empirical treatment, yes, both diagnostic laparoscopy and imaging combined with empirical treatment can be considered in women with a suspected endometriosis. There is no evidence of superiority of either approach, and pros and cons should be discussed with the patient. Next slide. Okay, so the treatment, when we consider the treatment, so suppose a treatment of women who present with the clinical features suggestive of endometriosis should be tailored to their individual presentation and the therapeutic needs. So if she is comes with a pelvic pain and desires non-desire of pregnancy, then treatment should be initiated with a medical emergency without even a definitive diagnosis. The primary treatment objective for endometriosis should go to manage the symptoms and tailor the treatment to the individual patients, taking factors associated with the disease and treatment into the consideration. Suppose in the patients with endometriosis, non-surgically and does not desire to become, hormone therapy is recommended for treating endometriosis or pelvic pain. Among the available hormonal methods, progesterone-only pills are considered as the first-line therapeutic management, and such treatment of endometriosis has a beneficial effect on pain and is not adversely affected with the future fertility. Next slide. So when you write a prescription for the pain, the first prescription writing will be a paracetamol NSAID, and the second will be the neuromodulators. These are for a chronic pelvic pains. So what is neuromodulators? When NSAIDs cannot be offered other than NSAID, this is either alone in combination with treatments. Neuromodulators can be given like tricyclic antidepressants, selective serotonin uptake inhibitors, and anticonvulsants like pregabalin. Next. Coming to the second, hormones. So first is like we are treating our basic painkillers, then comes with the hormones. Well, for a long-term management, combine the options of hormones. You have combined oral contraceptive pills, you have estrogens, you have antiprogesterone, you have GnRH agonist, antagonist, and LNG IUS, and danazole and aromatase inhibitors like letrozole. So it is recommended to offer women hormonal treatment as one of the options to reduce endometriosis associated with pain. Next slide. First, we'll go with the combined hormonal contraception. The Cochrane review says that OCPs will be more effective than the placebo for treatment of endometriosis. It's in 2018. So only 2 patients preference trials provided data on the comparison of different modes of administration, whether vaginal administration or as a oral pills or transdermal patch. So with past data, preference of one method could not be considered or recommended over the another. So there is no difference. The continuous OCP may be superior for dysmenorrhea recurrence. Continuous OCP use can be offered, although it is a weak recommendations. For instance, when patients with endometriosis prefer a regimen that reduces amenorrhea. The occurrence of breakthrough bleeding and possible consequential adaptation to medical treatment should be discussed with the patient. It is recommended to prescribe women OC pills either. So the recommendation finally, OC pills either is a combined oral pills, vaginal ring or transdermal to reduce, and option of continuous oral contraceptive pills can also be considered. Next. So coming to the progesterone, you have the various progesterone like depomedroxyprogesterone acetate, ciprotrone acetate, medroxyprogesterone acetate, norethindrone, norethisterone, desogestrel, dinogestrel, and gestinone as the only anti-androgens. The relevance of gestinone on progesterone is still a question mark. So with the progesterones, the efficacy, safety, long-term use, mode of administrations has to be discussed. Does not recommend, the GDG does not recommend danazol as a treatment for endometriosis associated pain and considered it no longer relevant to include anti-progesterone in the recommendations. So it is recommended LNG IUS or an etonergist rub implant to reduce the endometriosis associated with pain. So these are all the things or options. Now coming to the GnRH analog. GnRH analog, the mechanism is like the mechanism of action is it reduces it decreases estrogens, making an iatrogenic menopause. The points favor is it's very efficacy in reducing the pain symptoms, and the contraindications is like it has a short-term use due to side effects, and it causes hot flushes, and it has little high elevated cost. So these are the side effects. So what is the effect of GnRH on the bone and endometrium? Estradiol effect on the bone and endometrium. Estradiol, the need for estrogen is like when the levels is between 30 to 50, the endometriotic lesions of bone loss are minimized. So with the levels of very less, it is substantial bone loss. So minimum estradiol levels, we have to maintain the estradiol levels when you give any hormonal methods. We have to maintain the blood levels of estrogen levels between 30 to 50. So which have a beneficial effect on the bone as well as reduces the bone loss. And if the estradiol levels will more, then it increases the endometrial lesion growth. So whatever the methods, hormones, our aim should be maintaining the estradiol level to prevent the bone turnover. Next slide. So the GnRH agonist to be given to the patients to reduce the pain, although evidence is limited regarding the dosage and how long you are going to give. Is a second line, for example, if hormonal contraceptive progesterone have been ineffective, then you can recommend GnRH agonist due to their side effect profile, mainly because of the anti-estrogen side effect profile. You can consider using this combined hormonal therapy as an add-back alongside the GnRH agonist therapy to prevent the bone loss, hypoestrogenic symptoms. When you use that as an add-back, our goal should be the estrogen level to maintain in the blood level of 30 to 50. Next slide. Coming to the antagonist, whether it will be useful, yes, it is useful, but the evidence is limited regarding the dose and duration of treatment. It is also a second line if your OC pills and progesterones are ineffective due to their side effect profile. Next slide. Aromatase inhibitors like letrozole is the pain reflected to other medical or surgical treatment. We can use aromatase inhibitors as they reduce endometriosis associated pain. May be prescribed in combinations. It's an adjuvant therapy with contraception, oral contraception, progesterone, agonist or antagonist. Next slide. Okay, so now we discuss about the third generation progesterone, which is Dinogest. And compared to the other progesterone, it have an anti-androgenic effect, progesterogenic effect. Also, it maintains the estrogen level in the requirement level. So that way, it reduces the bone loss. So it's a property that it makes suitable for the endometriosis. Next slide. The relevance of estradiol levels, as I say, this again stressing the importance. In the postmenopausal woman, the estrogen will be decreasing, and that the woman of reproductive age, the levels will be 30 to 400 picogram. So next slide. So the bone turnover will be very high, bone turnover will be very high with a very high in the bone loss will be very high in this estrogen levels of between 0 to 30. And if the estrogen level goes beyond this level, the lesion growth will be increasing. Next slide. So as this is a repetition of the same slide. Yeah. So the maintenance of thing is like that. The Dynogest production produces the estrogen level with that range 30 to 50. So it has an additional benefit on the bone loss. Next slide. Okay, so when you compare to the for the 5 years overall, 5 years of Dynogest is well tolerated with minimal of breakthrough bleeding. Next slide. Okay, this is like pelvic pain decreases. How the long-term Dynogest treatment decreases endometrium-associated pelvic pain. So the baseline, the visual analysis of the pain score, VAS scores, baseline is very high. In 60 months, the total, the 12 and 24 months, the pain score is very less. Over the times, it will be little increased pain score, though from the baseline, it is very less. So Dynogest 2 milligram daily in 37 men with laparoscopically diagnosed. It is evaluation of the pelvic pain has been diagnosed at the end of 60 months following Dynogest treatment. The score has been from the baseline, it is decreased to very considerably. Next slide. Okay, this Dynogest leads to statistically significant reduction of endometrium volume and pain and management. So there will be the volume of the endometriosis decrease almost 66% in 6 months, and 12 months it is 76%. So the pain part, dysmenorrhea part, and overall the chronic pelvic pain, there will be a significant percentage of decrease of VAS scores. Next slide. This is again the bleeding profile. It is a favorite. Dynogest is the pattern of bleeding during Dynogest is acceptable by most of the women. Next slide. So if a patient woman with on Dynogest, if they have a breakthrough bleeding or spottings, that is because of the estrogen withdrawal very rare. So what do you do? So maybe if do an ultrasonogram, see the thickness of the endometrium. If the thickness is low, then management you can break the cycle for 5 to 7. Allow the woman have a proper recovery of the atrophic endometrium. We give the some estrogen to grow, and then short-term application of either 1 gram milligram oral or transdermal estradiol. If the thickness is more, then you can double the dose of Dynogest. If she is taking 2 milligram, then increase to 4 milligram per day for the next 1 month, then resume back to the 2 milligrams. So this is how you have to manage the breakthrough bleeding. If the patient complaining this is like a discomfort, then you can do the ultrasonogram and your management goes by that. So finally, the treatment of endometriosis. Basically, the safety of profile of oral progesterones is very high, and it is always superior to oral contraceptives because of the long-term effect of the endometriosis. Same way, the levonorgestrel IUD also, if you have a rectal pain, chronic pelvic pain with bulky diseases, probably if pregnancy is not warranted, levonorgestrel IUD also have the same effect. And like they are considered as the first-line therapies, progesterone as for early medical treatment of endometriosis. GnR agonists, you can only be the first days for a short term when they are not reached the maximum bone density. NSAID is very, very insufficient when the pain is very long term. For a short term pain, probably NSAID will be useful. So the first option is a long acting. We can take Dynogest. Next slide. So this is how the treatment. And if it is an endometriosis associated infertility, as Dr. Premlata Madam asked, you can directly opt for ART. If they fail to conceive, then go for the surgical management, or directly you can go for a surgical management. When you opt for the medical management, when there is no desire of pregnancy, then you go for hormonal treatment as well as a non-hormonal treatment, as I discussed. And whatever it is, post-surgicals and long-term treatment, you can go with the medical management. Next slide. So this is the current approach. What we are doing is, once you diagnose endometriosis, you do immediately first surgery, then you do a sandwich post-operative medical treatment, and then finally repeated surgery, and finally send to the ART. But what the treatment option has to be done, next slide, for a lifetime, this is like, these are the three main options. One is non-surgical diagnosis, directly treat with the long-term medical. If she following pregnancy, do a conservative surgery, send them to ART, and then again for the lifetime, go for the long-term medical treatment if the symptoms are there. Second option is like medical management, then directly go for ART, or directly once the diagnosis is made, send them to ART, make the lady to pregnant. And the third option will be like, whenever there is a desire to be pregnant, leave the medical management and send them to the thing. But your aim is, whatever the surgery, whether you do it early or you do it later part of the midlife, your aim is a one single complete conservative surgeries. Don't make her to go for repeated surgeries. Your first surgery will be the perfect and complete. Next slide. Finally, don't forget, whatever it is, I'm speaking about all the medical management. The problem focused strategies is like, one is the education of endometriosis, sleep and mindfulness activities. We have adequate sleep, good improve your immunity, doing a bed, good pelvic exercises as physiotherapy, diet, yoga, physical exercise, and manage work and study, and heat therapy, muscle relaxation, breathing exercise, and you have to accept the diagnosis of pelvic pain, develop a positive attitude. Thank you.
Thank you, Dr. Deepa. I know it's a vast topic, and I know you have done a very good job, and we very well said that the first surgery is the best surgery. Now I request chairpersons to give their final words.
Thank you, Dr. Deepa, for your comprehensive, for complete coverage of the medical management of things. It was well taken into account. Thank you, ma'am.
Jai Shri ma'am.
Well, 1 minute, just a call from the hospital.
Okay, madam. Okay, madam. We'll wait.
Deepa was telling about single complete surgery. As we know, the said and done, but it's very difficult. Many of these times, these patients, when they have a severe pain, they go for a surgical treatment, and by the time they take medical treatment. And when there is recurrence of endometriosis and the cyst is little enlarged, again they come us, and many times they land up in repeated surgeries and all. So the moral of the story is long-term suppression you are telling.
Yes, madam.
But out of all the medical management, which is the first line of treatment, you will be just giving medical management.
First up, we'll start with the pain management. Then, if not medical, hormonal, if you choose, my first option will be the progesterone, madam. Now, since Dynogest is available, we are preferring
whether you are going to start with the Dynogest first. I'm asking.
Yeah. But I want to tell you, I don't know whether it is a coincidence. Since we are using a Dynogest, recently I have a patient in ICU with a sagittal sinus thrombosis. She is on the second year of Dynogest. So I just reported into the Dynogest committee. So they are dealing it. But
maximum, I don't know how long they advise Dynogest.
So they are the studies has been quoted for 5 years. Okay, so many patients are taking second year, third year also. So some people are taking in adolescent.
Treatment-free period we have to give.
You have to see, madam, treatment-free period we can give and see whether the symptoms are bad. It's basically we are starting for the mainly symptoms. So symptoms, if we started again, many people will continue to use it. They will be worried about the chronic pelvic pain.
No, I think there's no rationale in giving a gap. There's no need to give a break.
Like,
yeah. 5 years, she was telling, no, there's just sagittal sinus thrombosis and all.
Yeah, recently I have, madam. The patient is recovering well, but I don't know the reason. Coincidentally, she also have a bacterial meningitis and sagittal sinus thrombosis. Maybe because of the dehydration, additional use of pills will cause us a thrombosis. We don't know. Anyway, I reported that case, madam.
When you are talking about GnRH analog and add-back therapy, that also not maximum more than 6 months we are telling. So only gynecologist, they are telling long-term therapy.
Long-term management.
Where your main aim is to have long-term medical treatment, only single conservative. So that's why I was asking. Thank you, doctor.
Thank you, everyone. Thank you. That was the very nice discussion also, because Dinogenes is the drug which we are using left, right, and center without knowing its long-term implications. And Deepa, just one small question. What all tests would you like to do when somebody is on Dinogenes? I know you had a patient with DVT, or as venous thrombosis, but do you do LFT or do you do a sugar, cholesterol, because they are on Dinogenes? Even for young patients, some teens who are having 3 centimeter, 4 centimeters.
So that is like an annual checkup only. I just tell them completely do an annual checkup. So now specifically, I'm not telling them to repeat the LFT or anything. But as an annual checkups, most of the patient, if you are above 35, they will be doing their sugars levels, lipid profiles, and LFT. So this is the first lesson for me, whether we need to consider doing anything else for those patients who are on long-term Dinogenes.
Yeah, thank you so much. Thank you everyone for this very interactive session 1. Now we will go on to the session 2, which is actually a very interesting topic. Now I call upon the chairpersons, Dr. Uma Maheshwari. Dr. Uma Maheshwari is MBBS, did her MBBS from Madurai Medical College, and she is MS Obstetrics and Gynecology from Sri Ramachandra University, Chennai. And she has a diploma in reproductive medicine from Kiel University, Germany, and former assistant professor at Institute of Obstetrics and Gynecology, Egmore, Chennai, and life member of IMA, Tapisar, ISAR, Oxy, and Foxy. Welcome, madam. Welcome, Dr. Uma Maheshwari, for this session. I also call my very close friend, and actually she's also a runner from Chennai Runners, Dr. Sukhada Rao. She's MBBS from Jawaharlal Nehru Medical College, Belgaum, and MD from Bangalore Medical College, and she's the managing director of Mohan Rao Memorial Hospital. Welcome to both the chairpersons. So now we have actually, after talking about the medical, surgical management and endometriosis in midlife, we have got a quietly different subset of topics, which is recurrent endometriosis. So I call upon Dr. Geetanjali. She's going to enlighten us about the recurrent endometriosis, the options for management, and how to tackle them. She's an undergraduate from Madras Medical College and postgraduate from Kiel Park Medical College. Her areas of interest being high-risk obstetrics, gynec endocrinology, and hysteroscopic procedures. She has completed her training in GDM and hysteroscopy. Geetanjali is an extremely hardworking person I have ever known. So over to you, Geetanjali. She's going to talk on recurrent endometriosis.
Thanks for the welcome address, ma'am. Thank you so much. And thanks Oxy Midlife Committee and the Chennai Menopausal Society for giving me this opportunity. Just a minute.
Yeah.
Are you all able to see my screen?
Yes. Yes, Geetanjali. Yeah. Recurrent endometriosis. Just go ahead. Yeah.
Hepzibah madam has already told that endometriosis by itself is a very confusing situation, and recurrent endometriosis is further confusing, as you all know. Okay, it is like a battle against an unknown enemy. Endometriosis, sadly, is prone to recur. The incidence varies widely. It is from as low as 6% to 67%. And to delay recurrence as long as possible would be the motive of my presentation today. Okay, coming to definition, there are various definitions. I have taken ESHRE guidelines as baseline of my presentation, and I have taken Foxy guidelines also, and World Endometriosis Society guidelines. According to ESHRE, the lesion recurrence on reoperation or imaging after complete excision of lesion. But this definition is little confusing because complete excision of an endometriotic lesion is practically impossible and scientifically impossible. There are 4 subtypes of recurrent endometriosis: symptom-based suspected recurrence, imaging-based suspected recurrence, laparoscopically proven recurrence, and histologically proven recurrence. So, before going into prevention and treatment of recurrent endometriosis, we should have a good knowledge about the mechanism of recurrence, the risk factors of recurrence, so that we can fetch the high-risk subgroups so easily and we can manage them easily. So according to Human Reproduction Update Journal, Volume 15, to investigate the causes of recurrence is an under-researched area. So researchers on risk factors for recurrence and time to recurrence may seem like two separate entities, but both taken together will give an idea about the cause. Understanding the cause is very important in preventing the recurrence. First, in situ regrowth of residual endometriotic lesions or lesions not completely removed during surgery, microscopic implants undetected at surgery, development of de novo lesions, lymph node and lymphovascular system involvement. This is possible in deeply invasive endometriosis. Immunological causes, estrogen receptor polymorphisms. Recurrent lesions may occur in 10% of patients even after definitive treatment, that is total hysterectomy and bilateral oophorectomy, for reasons unknown. And it may be a combination of these factors also. And coming to immunological factors, there are high CD15A expression in the peritoneum and peripheral blood of endometriosis patients. This high CD15A suppresses natural killer cells. So naturally, the endometriosis patients have deficient immunological function, and this paves way for a fertile ground for de novo or in situ implants, and this causes endometriosis recurrence. Why there is a discrepancy in endometriosis recurrence rate? As seen in the first slide, it is between 6 to 67%, almost 11-fold difference. Why there is such a difference in recurrent endometriosis? This variation is due to different definitions. Length of follow-up is very important. Study designs, sample size, type and stage of disease, type of surgery, post-operative medical treatment. There are many studies on recurrent endometriosis, but most of them are of very low sample size. The study design is not proper. The gravity of study is very poor. The length of follow-up is also very important. Many people, they are lost to follow-up. So length of follow-up, if we follow them only for more than 2 years or 5 years, we can get a conclusion. But many studies have length of follow-up of 1 to 2 years only. So there are nearly 24 to 25 studies on finding the risk factors for endometriosis. I have tabulated it here. And the younger age of endometriosis, the bilateral lesions are more prone to recur. And American Fertility Society staging is very important. High stage of revised American AFS staging and the revised AFS score more than 70. Size of the cyst, bigger the cyst, more chances of recurrence. High preoperative pain is indicative of high prostaglandin levels and cyclooxygenase 2 overexpression, and this also causes high recurrence rate. Presence of pregnancy is a protective factor, and hence absence of pregnancy is a risk factor. And previous medical treatment is a risk factor for recurrence. Completeness of the first surgery is very important, and the extent of surgical excision, that is the radicality of surgery, is very important. Painful nodules are prone to recur. Coming to pregnancy and recurrence, what is the correlation? Pregnancy is actually a protective factor because high progesterone levels suppress the growth of endometriotic lesions. It is anti-inflammatory and also immunomodulatory. Two scenarios, we can see scenario A and scenario B in this slide. A woman is failing to get pregnant, and there is a correlation between the increased risk of endometriosis also. So here there is a factor which is common to both these, that is failing to get pregnant and increased endometriosis recurrence risk. And this factor is the persistence of the in situ lesions or development of de novo endometriotic lesions. And this is a study. It included 366 patients operated for ovarian endometrioma, followed up for at least 12 months. Okay, they concluded that stage 4 disease and previous surgery for endometrioma are unfavorable prognostic factors. Studies on the pain and recurrence rate. We have 3 studies. The conclusion is that recurrence rates for pain and pain-related symptoms were higher than clinical recurrence rates, and pain and pain-related symptoms recur earlier than actual clinical recurrence. Duration of follow-up after surgery influences the recurrence rates. In this study, we can find that As the stage advances, the recurrence rate increases. Age-related recurrence rate of endometrioma after conservative surgery. Younger age is more prone for recurrence. Okay, 20 to 29 year age group is the recurrence rate is 43%. But when we see the 40 to 45 years age group, the recurrence rate is only 10%. The risk of endometrioma recurrence decreases with age. More than 40 years, post-operative medical treatment does not alter recurrence rate, but it alleviates symptoms. Okay, in this study, it is a good study. 1,080 women were studied. They had undergone conservative surgery for ovarian endometriosis. 2 years of follow-up was done. And they found out the preoperative medical therapy, painful nodules in pouch of Douglas, bilateral ovarian involvement, and largest cyst diameter or risk factors for recurrence. The protective factors are post-operative pregnancy and post-operative medical therapy. Okay, coming to biomarkers. Sorry. It is the most researched field nowadays because we cannot put all the patients who have recurrent endometriosis on post-operative medical treatment, because it also, medical treatment is a medicine, it also has its own side effects. So we cannot just like that put the patient on medical treatment. So there is one alternative for this. If we have good studies on biomarkers, we can identify the biomarkers so that we can find the subgroup of patients for whom the endometriosis is prone to recur, put them on targeted individualized therapy. So the side effects will be minimized. So these three are the promising biomarkers. They are under study. So estrogen receptor alpha gene polymorphism and cyclooxygenase 2 overexpression, an increased nuclear factor kappa B p53 immunoreactivity along with decreased progesterone receptor B immunoreactivity. So we need to know which lesions tend to recur. Okay, and this study gives answer for this. So it is deep ovarian endometriosis, which is it is more prone to recur than the other subtypes. For ovarian, it is 24.6, deep ovarian is 30.6. For superficial peritoneal, it is 17%, and for deep peritoneal, it is only 23.7%. Okay, what is the correlation between pre-op medical treatment and recurrence? It increases recurrence. Because of the preoperative medical treatment, the endometriotic lesions are masked during surgery, and the complete excision, the so-called complete excision of surgery, becomes impossible in these category of patients. So this preoperative medical treatment also alters the genomic process in endometriotic cells, the eukaryotic cells or progressive dyskaryotic expressions, and it also leads to recurrence. ART and endometriosis recurrence. Clinicians can perform ART in women with deep endometriosis as it does not seem to increase endometriotic recurrence per se. Okay, this is a very large study conducted in Turkey. Okay, see the time for recurrence. So this blue line is superficial peritoneal endometriosis, green is ovarian endometrioma, and orange is deeply invasive endometriosis. The recurrence time is almost the same in all the three subgroups. It is almost 30 to 32 months. What is the endometriosis subtype which recurs? See, in the x-axis, we can find the lesion type at first surgery and percentage of patients in the y-axis. And in superficial peritoneal endometriosis during the first surgery, the recurrence is of deep invasive endometriosis subtype mostly. It is around 50%. In ovarian endometrioma, it is the same ovarian endometrioma during the recurrent lesion. And in deeply invasive endometriosis, it is the deeply invasive endometriosis during the second surgery. Okay. But the superficial peritoneal endometriosis has progressed to deeply invasive endometriosis during recurrence. And many of the studies compare endometriotic cells to cancer cells in terms of invasiveness. It is evident from the subgroup C. It is superficial, but during recurrence it is deep. Okay, how to prevent recurrence is a very important question to be addressed. It should be aimed at stopping or slowing the disease process after confirming the diagnosis, and prevention of recurrence of pain symptoms or recurrence of lesion more than 6 months after surgery. Medical treatment. Medical treatment, we have to identify the high-risk patients who will benefit the most due to drug intervention. It is actually a challenge. Combination of drugs is always superior to a single drug therapy, and long-term recurrence rates are unaffected by even post-operative medical treatment, but the recurrence time is delayed. Okay, coming to hormonal contraceptives, Deepa madam has already explained in detail about all the medical treatments. I would just quote the studies and the implications of the studies. Okay, hormonal contraceptives, it causes consistent decrease in disease recurrence. So the duration of treatment should be at least from 6 to 24 months after surgery. It is effective in preventing dysmenorrhea, but not in chronic pelvic pain or dyspareunia. Okay, we have decided to give hormonal contraceptive. Which type of hormonal contraceptive? That is cyclical or continuous? I would say that continuous is better than cyclical because in continuous therapy, there is no periods related dysmenorrhea, and also there is no retrograde menstruation, which is an important postulated cause of recurrent endometriosis. So the protective effect depends upon the duration of treatment. Lesser the duration, lesser the protection. So choosing a patient for hormonal contraceptives is very difficult. We have to address the patient preference, look upon the side effect profile, and also see the efficacy, cost, effectiveness, and the availability in that locality when choosing medical treatment. Even though it is proven that hormonal contraceptives are beneficial as post-operative medical therapy, do all patients require such medication to prevent recurrence? Progestogens. They are anti-inflammatory and immunomodulatory. In patients who had undergone laparoscopy for endometriosis and had levonorgestrel intrauterine system, dysmenorrhea is lower in levonorgestrel intrauterine system and compared to expected management group. Okay, what about this subgroup of patients? I just want to highlight this point. Progesterone receptor B downregulation is found in about 9 to 12% of patients in the normal common population. So how are we going to find these patients, or without finding these patients, are we going to give oral contraceptives and progestogens as such? Because they will not be responding to either progestogens or hormone replacement oral contraceptive pills. Okay, this is a meta-analysis of 7 studies. In postoperative pain reduction, LNG-IU is comparable to GnRH agonist. In decreasing the recurrence also, LNG-IUS is comparable to oral contraceptive pills and danazol. In patient satisfaction survey, LNG-IUS has scored much more than the oral contraceptive pills. And the only drawback with the LNG-IUS system is irregular vaginal bleeding. Dionogest, LNG-IUS or placebo. This study confirmed the efficacy of Dionogest in pain control and prevention of recurrence, and no conclusion on the superiority of LNG-IUS over Dionogest. They both are comparable. Foxy Good Clinical Practice Guidelines recommendations say that GnRH agonists 6 cycles rather than 3 cycles prevent recurrence of endometriosis. What should be the duration of medical treatment? For GnRH, at least 6 cycles should be given. For oral contraceptive pills, at least 2 years of treatment is required. Okay. What about the surgical techniques in preventing endometriosis? Mala madam has already explained in detail about the ovarian endometrioma excision. Excision is always better than ablation. It applies for all the lesions. Okay. For ovarian endometrioma, cystectomy should be done rather than drainage and electrocoagulation. At present, no firm conclusions on the effect of surgical techniques on the recurrence of deeply invasive endometriosis. And we have to try our best to avoid dissemination of lesions during first surgery. During repetitive ovarian surgeries, we have to take care to minimize the damage to ovaries. And deeply invasive endometriosis, we should not touch without proper expertise. If we feel that we don't have expertise in dealing with deeply invasive endometriosis, just refer her to a specialist. Hysterectomy, we have to always do a total hysterectomy. Even in patients who had undergone hysterectomy and bilateral salpingo-oophorectomy, the recurrence rate is 10%. For bladder and bowel endometriosis, special team approach is very important, and radicality of surgery is also very important. Less radical the surgery, more the recurrence rate. Take home message: to delay or to eliminate recurrence is an unmet medical need. Adherence to best surgical practices during primary surgery is very, very important. Patient selection for post-operative medical therapy is very important, and more research is needed in identifying biomarkers for recurrence. Preventing or delaying recurrence of endometriosis is every gynecologist's duty. Thank you.
Thank you, Dr. Geetanjali. That was a very nice presentation. I really appreciate the fact that you brought in there is a lot of molecular techniques and molecular bioinformatics involved in endometriosis, where they are trying to analyze both utopic and ectopic endometrium. Thank you so much for the presentation. Now I call upon the next speaker, Dr. Anshu Bansal. Dr. Anshu Bansal is a very good friend of mine, and she's a practicing gynecologist since 2002. She's attached to First Med Apollo Hospital and Aisha. Her specialty is high-risk obstetrics, endoscopy, and public health education. And she's been a DNB faculty, and she's affiliated to RCOG, Oxy, and Tamil Nadu Medical Council. And Anshu is going to talk us about alternative therapy in endometriosis. I'm sure all patients are actually trying to go to that to avoid the effects of hormones and medications. So let us see what Dr. Anshu has to talk about alternative therapy in endometriosis.
Thank you, Karpagam. Thank you, Karpagam.
Thank you so much. You can start. Thank you. I just tried to mute it. So you can go ahead, Anshu.
Yeah. Okay. So can I have the earlier slide? Yeah. So as Karpagam says, alternative treatment. Now, everybody comes to alternate treatment only in special cases, either when allopathic management is just not working for them, or when they have tried everything and still they have failed, and now they are here with alternate treatment. Next slide. So what are the debilitating symptoms which really need the patient of endometriosis, which needs to be taken care of? So the patient has pelvic heaviness, intense cramping, abdominal pain, lower backache, bladder pain, painful bowel, pain with sex, and worsening depression, anxiety, or irritability, again caused because of the pain. Now, so next slide. So basically our main battle is pain. Pain at the center, pain on urination, pain on sex, and pain and depression because of pain. So we are actually fighting pain and not infertility when there is endometriosis at midlife or perimenopausal. Next slide. So what is the goal of alternate treatment? Are we trying to cure it, or are we trying to alleviate symptoms? That would be really, really nice if we could cure it. But even the allopathic methods in which we've had so much of basic research, we have not been able to cure. So definitely alternate treatment again is only trying to help with symptom alleviation. Next slide. So what are our choices? There are many, many choices here. When I actually read up about it till now, we were all going through all the medical management and various surgical managements, but there are a lot of other choices too, like behavioral modifications, lifestyle changes, then of course TENS, acupuncture, there is physical therapy, biofeedback, and alternative medications such as Ayush and traditional Chinese medicines. All these, a lot of these actually have had a lot of research, and there's a lot of evidence on the supporting these, but nothing is really able to take care of even 50% of the problem. And that is the reason all these are still within the alternate treatment modality. Next, please. So what is behavioral modification? Behavioral modification is actually something more psychological. This was studied more in COVID times when treatment was delayed and the patient was told to wait for the surgical management and sometimes even for the medical management because patients were just not seen at that time. It focused on both the physical problems and the emotional issues of stress, anxiety, and depression. So it focused on cognitive behavior therapy, Cognitive behavioral therapy included relaxation and mindfulness to relieve pain, and ACT, or acceptance and commitment therapy. Basically, they were trained to accept that they had a chronic illness, and by accepting it, they were able to have a more positive attitude towards it, and thereby they were able to be able to deal with the pain and the psychological impact of it. Next slide. Next slide. There are a lot of review articles, but the conclusion was that cognitive behavior therapy have shown to be useful in alleviating pain. However, how is it done? So more structured studies are required to formulate consistent, clear, and replicable methods to reach a psychological intervention program for such patients. Next slide. Aside from this, lifestyle changes, as we all know, and as we were having a discussion earlier in the day, lifestyle changes really help the body in every way. These changes are focused on what we eat, that is nourishment, exercises, yoga, meditation, and correct weight maintenance. All these help to improve the body's immunological competence, thereby helping in reducing and/or fighting with inflammation. It also improves muscle strength, depression symptoms, and helps provide an overall positive outlook. Next slide. Transcutaneous electric nerve stimulation. Direct electric stimulation of the skin overlying pain trigger points. This may be helpful in deep infiltrative endometriosis, especially in deep infiltrative endometriosis. And if it helps, then a TENS machine can be bought by the patient and used as home care. However, still we only have preliminary studies, and a lot of studies have not been done with TENS in endometriosis. Next slide. Next slide. Acupuncture again is similar to TENS. Here we use needles and we are able to stimulate some nerve points. Some studies are there which show a significant reduction or regression of pain. More and better quality studies here also are required to ascertain the usefulness. This is a Chinese therapy, and unfortunately, we do not have many studies on acupuncture outside of China and Singapore. Next slide. Physical therapy. Here, the physical therapy is about massages and about joint mobilization. Again, trigger point therapy, something like acupressure, deep tissue massages, pelvic floor exercises, and joint mobilization. There were some studies on physical therapy which have shown to be of help, but nothing which has shown us of any significant changes in the endometriosis. So we don't have any significant studies of physical therapy on endometriosis. There's a lot of material available on physical therapy, but not much on physical therapy on endometriosis. Next, please. So biofeedback. Biofeedback is again mind over body. Here the pain signals, here the way it is that the mind then takes care of gets the pain signals, and then you get the neural response. So with certain feedback methods, which can be either electrical or thermal, the mind over body can be stimulated and you can better the pain that way. That is how biofeedback works. But again, biofeedback has not shown, there haven't been many studies which have shown any definite advantage of biofeedback on endometriosis. Next slide. Ayush in endometriosis. Ayush is having a lot of comeback in today's date. A lot of patients actually get tired of us and go to things like naturopathy and homeopathy. A lot have even tried Ayurveda. None of these have shown till now to have any impact on deep endometriosis. Nothing has shown an impact on endometrioma. However, superficial endometriosis can in some cases reduce with homeopathy and Ayurveda. Next, please. So it's an old traditional medication which is seeing a revival. However, again, many good quality, good quality researches are required. Only case studies and clinical experiences are available when you dig deep. You do not get any good quality clinical researches. So it has a long way to go. Next. Traditional Chinese medicine. There are a lot of articles on traditional Chinese medicine. However, although there are many studies which are available, but most of them are either done in China or again Singapore, Malaysia. Unfortunately, we are not very clear about these studies and how much of the correct, how much of the thing to rely on. So the studies which are available, they are showing a significantly reduced pain, and in many studies, there's also a reduction in the lesion size. Traditional Chinese medication is not just medication given orally, but also application of these medicines, and many are even enemas that are given, and they are said to reduce the lesion itself, especially the deep infiltrative lesions. Next slide. In conclusion, all the alternate medications are aimed at reducing and managing pain. More extensive studies are needed, and standardization of reproducible methods are required. Objective quantification of pain relief is also required. So they are saying that they are reducing pain, but there is no objective quantification of the relief. Thank you. Next slide. Thank you. Karpagam?
Unmuting. Yeah, unmuting. Yeah. I just thank you so much, Anshu. It was really very nice, because I know many patients actually try other therapies because they are fed up with taking medications for a long time. I request the chairpersons, Dr. Sukada and Dr. Uma, to say a few words.
Thank you, Karpagam. First, regarding this recurrence of symptoms can be a nightmare both for the physicians as well as the patient. Dr. Geetanjali, you have done a very good job. You nicely summarized the various studies. There was quite a number of studies that you have categorized and explained. And you have also given us the important tips in prevention as well as given the management strategies. But I just have one question. If suppose you have a patient who has had a recent surgery who comes back with again pain, and there is on ultrasound, there are cysts, do you recommend repeat surgery, or you'll go with medical management?
Medical management is actually a tricky thing, because it can, while we are going in for a recurrent second surgery, it may mask the lesion again, and again it may go in for a second recurrence, ma'am. So it is actually beneficial not to start her on any medical therapy, that is hormonal therapy. Just give her pain alleviating medicines alone, like NSAIDs, paracetamol, and then follow her up. And then when the cyst reaches a size that it should be removed, then we can remove it by recurrent surgery.
Anshu ma'am, I have a question for you. Have you ever used any of these methods like TENS or anything for this pain alleviation? Because in some fertility, the patients who need fertility treatment, the pain is a very big issue, and we can't load them with hormonal tablets as well. So in that case, what is your take on it, ma'am?
To be very frank, very good, definite improvement will be seen by yoga and by lifestyle changes. TENS is definitely useful, and in many cases, even acupressure. I have not used acupuncture, but acupressure is also useful. Since they are alternative treatment and we are not really supposed to be offering them, I have not offered to too many patients, but yes, they are of some benefit. I would say 30%, but I think 30% is a lot when we are talking about severe pain.
Thank you, ma'am.
Yes, Sudha.
Yes, as you rightly said, the pain is management is most vital in this endometriosis treatment. And yes, any kind of form of therapy that will alleviate the pain is welcome. But do you know how many sessions of these physiotherapy or physical therapy sessions are required for a patient to get some relief at least?
Definitely. Almost, I would say 3 to 4 months are required. Some relief comes in 2-3 months, 2 months, I would say. But the relief definitely increases if they continue. But you see, by then, hopefully they get pregnant or they just decide they've had enough. Yeah. Because the pain
Mostly
is
it
quite
will be.
severe. Yeah.
But if we are handling them, invariably would have put them on painkiller tablets as well, isn't it?
Definitely. But, painkiller doesn't help so much. I mean, how much can you give? Especially when you are going for fertility treatment, how much medication can you load a patient on? So whatever helps, I feel, is what is worth it. And there's no harm in things like TENS and acupressure. Acupuncture, I personally don't prescribe because I don't know what needles are used and how it is done. But acupressure, I'm kind of, it's like a massage. So yeah, but
that was a very nice presentation.
Thank you.
Thank you so much. Thank you, Anshu. It was really nice because I know we all know pain is a very subjective symptom. And so I think even the therapy also is more subjective because one patient may say relief with one complementary therapy, the other may not. So I think we really have to have a tailor-made approach of each and every aspect in endometriosis rather than have a blanket
and
policy.
one more thing, Karpagam, if they like the person who's giving the treatment, they are happy and you really feel that they are getting improved. If they are happy with the person who's giving the medication, the person who's doing the TENS or the person who's doing, if that person is a nice person and, basically does it with empathy, they are happy and it helps them. So there's a lot of huge psychological impact over there. I think I've gotten frozen. Karpagam, can you hear me? Sukada, are you there?
Yeah, we can hear you.
Yeah.
I can hear you.
Yeah. I think, yeah. Yeah, so Deepa, I think only we are there.
Are you? Okay. So,
Anshu, I'm also there. Anshu, I'm also there. Don't worry.
So may I invite our secretary? Thank you. It was a very nice CME. So to conclude, I'll invite Dr. Tamil Selvi.
Deepa, I have a very bad sore throat. Can you do the vote of thanks, please? If you don't, I've really got a very bad sore throat.
Thank you.
I don't think.
No, thanks, Tamil. At least you joined. Okay, and it was a very, very nice meeting. Thanks at Chennai Menopause Society as well as Oxy Midlife Committee. And thanks our chief guest and guest of honors and all the chairpersons, Dr. Jaishri Madam, Premlata Madam, as well as Shukada and Dr. Uma. Uma is my classmate, in my UG classmate. Thanks, Uma. And thanks, Karpagam, for beautifully you just mastered this show. And at last, many thanks to our president, Chennai Menopause Society president and Oxy president, Madam Jairani Madam, as well as Hepsi Madam. And thanks Shield, Chitrakala and the whole of Shield teams for giving us a platform. And it was a wonderful meeting. We'll meet again soon as a combined people meeting.